the new king of peptides, and those are GLP peptides, the Mounjaros and the Ozempics of the world, tirzepatide, semaglutide. Everybody seems to be on them, superstars. I mean, you can't go to a doctor without getting a prescription for this stuff. And there's been a lot of doctors that have demonized this medication. We have a totally different take on these medications, the importance and the relevance of this medication in today's landscape. Hey guys, welcome back to another edition of Beyond Biohacking Brothers. I'm here joined by my usual basement brothers, Miguel and Dr. Rudy. And today we're happy to have you back, Rudy. You come back from some conferences and stuff, so we'll talk about that on future episodes. But for now, we are going to follow up our peptide talk that Miguel and I had to talk about the new king of peptides. And those are GLP peptides, the Mounjaros and the Ozempics of the world, tirzepatide, semaglutide. And, you know, the reason why this is such an important subject is because of the chronic epidemic with obesity that we're seeing today. But more importantly, I know that everybody listening to this podcast was probably heard a ton of them. You know, everybody seems to be on them, superstars. I mean, you can't go to a doctor without getting a prescription for this stuff. And there's been a lot of doctors that have demonized this medication. And I know that you, Rudy, have a totally different, and us as well, we have a totally different take on these medications, the importance and the relevance of this medication in today's landscape. And I feel like you are the most qualified person to really be talking about this because Dr. Rudy went to residency. He was hospitalist. He was one of the very few doctors who actually took nutrition courses. And then he made a decision in his life where he said, I no longer want to be part of the system that is treating illnesses, and I want to get into prevention medicine. And the lowest hanging fruit is nutrition, so I'm going to treat that. And so you and your wife, 17 years now, open a weight loss clinic.
19 years.
19 years now, you open a weight loss clinic. So you have treated weight loss patients, over 5,000 that are currently active in your clinic and your other practice. And you've seen every medication, every drug, every iteration of weight loss that there is, including GLPs that you started using since 2008, I believe, with 2005 with diabetic patients. Yeah. So in terms of your expertise, your knowledge in the trenches, you know the physiology, you know the science, you know the studies, but just in the trenches with patients, how this has transformed lives. And so that's why I feel like you're the most relevant doctor to talk about this. And I'm just going to kind of open the floor of you because I know this is an area of passion for you. So listener, beware and get ready.
Buckle up, baby. You know, this is my favorite subject to talk about. The king of peptides, GLP-1 peptides. Lots of misconceptions, lots of misunderstanding of what that is. It is so much more than just a weight loss peptide, a weight loss medication. And I'm going to go through my whole journey and the journey of GLP-1 and to show you the impact that it can have not only on our healthcare system, but on society. That's how deep it's going to be. Yeah. And this episode is about celebrating the discovery of this amazing pathway, the GLP-1 pathway, that was discovered back in the 80s. So the first GLP-1 medication was placed in use and FDA approved for diabetes in 2005. Coincidentally, that's when I started my weight loss practice with my wife, Keisha.
Was that exenatide, by the way?
So the first GLP-1 was exenatide.
Which you have to inject twice a day, I remember. If not wrong.
So no, in the beginning was daily, then exenatide or Bydureon was the brand name, became weekly. Really good for diabetes. So I started using it at my primary care practice. Yeah. And I work with an Indian tribe in the Miami area that has a reservation where I'm the medical director. And unfortunately, Indian Americans have a very high incidence of diabetes. And what I realized is that diabetes is mostly because of poor diet choices, but a lot of insulin resistance. So when I went to work there, it was about 2005, I went to work there around 2008. I started using in my other primary care practice exenatide a little bit, and I saw the difference in diabetes, but we were still using at this time sulfonylureas, things like glyburide, and insulin, including metformin for diabetes. We had nothing else. I use exenatide a little bit. So when I went to the Indian tribe reservation, that we started seeing that exenatide would give me results where the A1C would go from 12 down to 5, down to 6
in a very short period of time.
And I was like, wow, what medication is this?
That's a huge jump.
Huge number. And those patients were on insulin. So what I've done at that primary care practice, we had about 150 diabetic patients. I took out 95% of my patients off of insulin, and I put them on exenatide, the GLP-1 that was available at the time. And like we had tremendous success in diabetes control. And once you control diabetes, the trickling effect is that you have less heart disease, less vascular disease, so much improvement. So I took out almost 95% of my patients off of insulin. And what I want for people to realize is people need to realize that type 2 diabetes is a reversible lifestyle disease. Amen. So a lot of times when people get a diagnosis of type 2 diabetes, they think, okay, I'm a diabetic. No, you're not a diabetic. You happen to have diabetes. If you have type 1 diabetes, which is an autoimmune disorder,
there you need insulin.
You have that for life. You have that for life.
Yeah, no, if you don't take insulin,
if you don't take insulin, you go in ketoacidosis. It's bad. But type 2 diabetes, it's mostly a matter of insulin resistance that can be treated with the right lifestyle choices and now the right chemicals, the right chemistry to reverse that insulin resistance. And my first view about GLP-1s was this, and I was like, what is this medication that's reversing diabetes on my patients where they could never do it before? Yeah. So I've used exenatide mostly from 2005 to 2014. 2014, another set of GLP-1s came to the market, and that was the liraglutide, Saxenda, Byetta, dulaglutide. So those now got FDA approval for weight loss in 2014 without having diabetes. But they weren't great. So I've used Saxenda a little bit in 2014. Maybe patients would be losing 10 pounds, 15 pounds. They weren't great. But I used them, but they weren't my preferred agents for weight loss. I was still using mostly the FDA-approved medication like the stimulant class, the phentermine, the diethylpropion that have been FDA approved since the 70s. And everybody who's trying to lose weight have tried those. Stimulant type medication cuts your hunger but increases your heart rate. You have insomnia, constipation. They still work. I still use them, but they weren't the end all of obesity. But at this time, again, I didn't use Saxenda that much because they weren't that much better. The weight loss wasn't great. And then in 2017, I don't know what they did to the molecule of GLP-1. Ozempic came out, semaglutide. And then all of a sudden, that's when you started seeing 50-pound weight loss in 4 months, 70-pound weight loss. It became a cultural icon. Kim Kardashian took semaglutide and talked to Ozempic and talked about it and put it on her social media. At the Academy Awards that year in 2017 or 2018, they were making jokes on everybody because people were losing weight like crazy. So again, this is where I appreciate human innovation spirit, because the GLP-1 molecule was first discovered through the saliva of a lizard. That's where they isolated it in the 80s. It took them almost 20 years to come to a drug to the market in 2005. And it took them 12 years in 2017 to really come with Ozempic that really, I don't know what they did to the molecule. Why is semaglutide so much better for weight loss compared to Saxenda, compared to exenatide? I don't know what they did to it, but it was a success. Weight loss like crazy. So I've used a lot of semaglutide when it first came out. In the beginning, I was a little skeptical. But when I saw the results, I was one of the first one. I switched a lot of my patients for semaglutide for weight loss.
Doc, before you lose people, let's just, first of all, a disclosure for purposes of the talk, because you're saying semaglutide, people don't know what semaglutide is, right? They know by the brand name. So let's clear the air in regards to what we're using here. We have Ozempic, which was used for diabetic. It was approved through medical insurance for
If you don't mind, let me go because
make
it's a
sure,
little
but make
confusing.
sure that you
Yes.
describe semaglutide, what it is, and then tirzepatide. But we're using the chemical compound. We're
Well,
not,
I'm using both. So semaglutide is what we call the generic name. It's the name of the chemical formula. That's the generic name. Then there's two brand names associated with semaglutide. Number one is Ozempic. That's the one, again, it's semaglutide, but it was FDA approved for diabetes in 2017. Then Wegovy, brand name Wegovy, the same exact semaglutide was FDA approved for weight loss without diabetes. And what they did with Wegovy, they allowed the dosage to go up to 2.4 milligram, whereas Ozempic was only up to 2 milligram. But what I try to explain to patients, it's semaglutide. Whether you call it Ozempic or Wegovy, it's semaglutide. At my practice, whether it's my weight loss practice or at MHI, I use a lot of compounded semaglutide.
That's what I'm talking
But at my primary care practice, I use brand name semaglutide because those are for my diabetic patients.
Which is the Ozempic and the Wegovy.
That's the Ozempic and Wegovy. And then in 2021,
second generation,
tirzepatide came out, which was, I call tirzepatide the iPhone 15 of weight loss because they improved on semaglutide or Ozempic. So they actually done studies where they compared semaglutide. So I'm going to call them by their generic name because it's easier. If not,
no,
we get
and for legal disclosure, we're using in our practice, we're using the compounded form of these molecules. Okay,
but I'm going to talk semaglutide and tirzepatide because that's easier. I am what we call agnostic to any of those names. I love the GLP-1 compound because what it can do. Whether you call it whatever it is, they're great. So I'm going to say semaglutide and tirzepatide. So 2017 semaglutide came out and was a game changer, but it had more side effects. I had about 30% of my patients who would get some significant GI discomfort, nausea, constipation, vomiting. Most people would tell me, I don't care that I threw up, I'm still going to stay on it. I managed those side effects, but it was tough. I was getting a lot of calls at my practice. Then in 2021, they did something else. Eli Lilly came up with tirzepatide, brand name Mounjaro, that was FDA approved first for diabetes. Then after that, Zepbound, the exact tirzepatide, exact dose, same chemical formula, FDA approved for weight loss. And tirzepatide is so much better than semaglutide. Again, I don't know what they've done to those molecules. The one thing we know with tirzepatide is the first and only GLP-1 medication that added a second receptor goal. So it also targets the GIP receptor. And I think, and that's what experts think, is that this is what made the huge difference between tirzepatide and semaglutide, because GIP tends to be more of a fat burning type of molecule. We don't understand everything about GIP. Metabolic rate and fat. They actually found GIP receptors in adipose tissue. So it causes lipolysis. So tirzepatide is both an appetite suppressant and a true fat burner.
Right.
So the results of tirzepatide versus semaglutide are much better. So much so that in my weight loss practice, I barely use semaglutide because I think tirzepatide is superior for most patients. I have a few patients.
When you compare the two, it's almost like semaglutide's a lot more bumpy. Like there's a lot more side
effects. Yeah, but there are some patients.
But we used it very successfully.
Yeah, very successfully. It's still semaglutide is still like a great medication.
And by the way, in some people, like we have some patients that actually they go to tirzepatide and then go back because there are those that are looking for that appetite suppression.
Extra appetite suppression.
Yeah, because it's a lot heavier on the appetite suppression. And some people feel like they just need that to control.
So we don't have a lot of time, and the points that I want to make mostly with the GLP-1s is you hear a lot of noise on social media, and you'll hear a lot of doctors talk negatively about GLP-1s. Yeah. And I agree, we need to talk about the side effects because they do have side effects, but we're not going to throw away the baby with the bathwater. Just because there are bad side effects, that's not why we're not going to use them. We can mitigate those side effects. And let me go over the list of side effects that can happen. Because one of what GLP-1 does, it slows down your digestion. Mm-hmm. It causes what we call a mild gastroparesis, where the whole digestion of the stomach, it slows down. So because of that, you can experience acid reflux, indigestion, constipation. Those are the most common ones.
But the funny thing, some people can have constipation or diarrhea.
Which is like
completely opposite.
It's weird.
It's weird.
But people will tell you that. And if you eat the wrong foods, if you eat fried foods, if you drink alcohol, if you eat processed foods, people will tell you, all right, this one didn't go down. So indigestion, but most people will kind of know what foods to avoid, how much to eat. And you'll notice that people who take those medications are going to crave healthier foods because they feel better when they eat healthy. So that changes that. So when it comes to GI side effects, that's not a reason not to put patients on this. The big question is the acute pancreatitis that can happen with those GLP-1 medications. And I'm going to tell you, I've seen one bad case with the old generation back in 2009. I actually had a patient in the hospital because of this. But since then, with the new generation, we don't see it much. It can happen, but we don't see it as much or as bad as what we used to see. But I still tell my patients that. Yeah. The big question mark is, what about thyroid cancer, right? There's a FDA has a black box warning that those medications may be associated with thyroid cancer.
Medulla therapy.
And I just want to make a stress of points for clarity for people in terms of safety, because you hear a lot on social media about, the stomach paralysis, and like they talk about the really bad side effects, which exist, but they're outliers, at least in our practice, and you've treated thousands and thousands of patients with this. I mean, the amount of people with really bad side effects has been very, very, very minimal, if at all.
But I think it also comes down to traditional medicine just prescribing based on a symptom, and there's not they're not implementing the appropriate diet, the proper nutrition. People continue to eat their fried food or just toxic food that's probably causing some form of reaction.
And I'm going to tell you, for example, I saw the case of that patient, not the case, I didn't see the case, but I read about the case that they talked everywhere about gastric paralysis, was on social media. And this is a patient that's been taking high dose for a long time.
That's the point.
Was complaining of recurrent nausea, vomiting, and they kept the patient on GLP-1.
Which, by the way, happens a lot.
Yeah, and some of my patients, I tell them, okay, for you can't tolerate it. I'm sorry. That's not a medication for you. Extremely rare.
Yeah, we had one patient that went to the hospital, and the reason when he went to the hospital on his first dose is because he made a mistake, and he acknowledges that he made a mistake when he read the prescription, and he did it 10 times what he should have done.
So you got to be careful with the dilution, with all those things. So great point on this. And the point I wanted to finish with the thyroid cancer, it is because when they were doing rodent studies back in the 80s, only in rats and mice, they saw that there was a slight increase in a very specific form of a rare thyroid cancer called medullary thyroid carcinoma. Medullary thyroid carcinoma is really rare. I've seen one case in my 25 year of medicine. That was back when I worked at Jackson Hospital, because it's usually associated with something we call multiple endocrine neoplasia type 2, men type 2. And people who have this, usually it's 50% of the family will have thyroid cancer or some kind of endocrine cancer. Extremely rare. Right. But still, we worry about this. I always ask patients, do you have a family history of thyroid cancer?
Don't rats have an overwhelming amount of thyroid, thyroid glands?
I don't even know. I don't treat rats. I don't care about rats. I care about
We don't
humans.
treat rats. We treat humans.
And there's a study that came out from the European Medical Agency, which is the equivalent of the FDA in Europe. And they followed almost 2 million people for 7 years of patients who've taken GLP-1s, whether continuously or on and off. And they did not see an increase in thyroid cancer. Right. So, I hear people and doctors saying all the time, I'm going to wait for the long-term studies. We've had GLP-1 for 20 years. Yes, Ozempic, semaglutide came out in 2017, but GLP-1 as a class has been for 20 years. And then now the studies that we have on long-term studies like the SELECT trial, where they looked at cardiovascular mortality, that you've seen that patient had a 20% decreased risk in major adverse cardiovascular events. 20%. And do you know what was even more amazing in that study? Is that they saw that the cardiovascular risk started showing up 3 to 4 months after the patient started the medication. It's not even the weight loss that caused it yet. So what the scientists deduced from that is because they also measured inflammatory markers like TNF-alpha, IL-6. Those inflammatory markers go down. They go down and we talk about inflammation all the time. Right? How do we decrease inflammation? Right. GLP-1 decrease inflammation. So they've seen that the decrease in cardiovascular risk happened almost independently from the weight loss. Right. How amazing is this? And
it looks pretty promising that they started, 2015, 12 years later. And then now we have, 7 years later, we have tirzepatide. Yeah. And I mean, the future in the next 2-3 years, it's going to be incredible.
And great point. So just to clarify for the listener, because look, we're not here sitting promoting semaglutide and tirzepatide that, as a medication in the sense that, everyone should take it and not change their lifestyle. Like the reason for doing this medication is to help people, give them the sort of like momentum and the coaching along with it so that they can remove the problem that started in the first place. And, one of the things that you're big on, and maybe you can pounce on us so people can understand why you're passionate for GLPs. I mean, there is no changing. I mean, the genie's not going back in the bottle. Like 88% of America is on some form of metabolic syndrome. Right? More than 50% of our population is obese. More than 50% of our teenagers and our kids are in this category. I mean, this was unheard of 40 years ago. We have an epidemic of obesity. We have an epidemic of insulin resistance. And, the food industry is not getting any better. So yes, the lowest hanging fruit is always nutrition. The problem is that some people's bodies, and maybe you can expound on this, are addicted to food and sugar. Their bodies are addicted to this.
And that's the most important point that we need to discuss. Because first, I consider our food now a weapon of mass destruction.
For sure.
So hear that again. Our food is a weapon of mass destruction, because our food is a
industrialized food, right? Like processed, ultra processed foods.
The what we call the SAD, the standard American diet, is a weapon of mass destruction, because it's causing the crisis of obesity, the cardiovascular mortality, the cancer, obesity-related cancer, neurodegenerative disease like Alzheimer's, Parkinson's disease.
9 out of the 10 top killers of men.
9 out of 10 top killers are related to metabolic disease. So I compare a lot GLP-1 discovery to the discovery of antibiotics, of penicillin in the beginning, in the 1930s and 1940s. Why? Because at those times, what killed us back then was infectious disease. We needed the antibiotics and completely changed healthcare. What's killing us now? Metabolic disease.
Right.
What can improve metabolic disease like nothing else is GLP-1s. So, and to go now back to the willpower question of obesity, that's when it changed my mind. And this is what I want people to understand with GLP-1. We used to think that obesity was just a lack of willpower. So we thought that people who were overweight just didn't have the willpower and the discipline to what they're supposed to be doing.
Or the education.
Yeah, or the education. And nowadays with the internet, there's enough education. Everybody who comes to my clinic knows what they should be doing. They just can't do it. So now that we have a hormone, and let me backtrack a little. So at first we thought GLP-1 were only in the stomach. Slows down your digestion, decreases your appetite, that's why you lose weight. Well, they discovered that there's a lot of GLP-1 receptors in the brain. So it is a psychoactive medication. It's not just a stomach medication, a GI medication. It's a brain medication. And it does something to our reward system, to a dopamine system that we don't understand. Because when people take that medication, they will tell you, I love that word, that term, the food noise is gone. The chatter is gone. Because people who deal with weight issues and with food, and we all have a little bit of food addiction.
Yeah,
all
everybody.
Of us. It's the most common addiction and the hardest to treat, food addiction, because we have to eat, and the food is there. And
it's so normalized.
And they know how they engineered the food to taste so damn good, right? Oreos are more addictive to the brain than cocaine.
Yeah, I mean,
right?
what I say, there's hyper concentrated food byproducts that are not food, like oil, sugar, and salt, which is laden in all our foods, and they're caused to create that addiction pattern, right?
So we all have a little bit of addiction.
But just so, because we're gonna have to close out soon, I think one more detail that we definitely need to touch and to create awareness for other people taking these drugs is to implement not only the proper nutrition and proper exercise regimen, but also, I mean, what I like to tell patients, when you're on these meds, right, the food noise turns off and they'll go 16, 18 hours fasted, which is really good. But the science shows on a fast, the most important thing is how you break it. And if you break it with rice and beans, you're causing an inflammatory response, which is a double-edged sword. Although I get it, there's many more benefits than cons. We still have to explain to patients, hey, the proper way of breaking your fats. And one more thing, also the degradation of protein, which your body breaks down the muscle, because they're not intaking enough protein throughout the day. So you have to supplement strategically with specific molecules that are A, missing in our soil, and B, you're depleting yourself even more when you're going for hours on end without eating. So it's not only taking the GLP. If you want to do it correctly, what supplements could you support the GLP to function better, and so you don't break down your body?
Completely. And this is what, again, I'm talking a lot today. I'm
we
sorry,
can talk
this is
2
my
hours on
subject,
this.
but the points that I want to make that are really important is, first, you use the GLP-1. So I'm known in my community now as the guy that can really help a patient go from non-compliant to a gym rat, to a completely changed person. Because when I see my patient, I let them know, I understand you, I get you. It's not that you're weak. You have a disease, you have a hormonal imbalance.
What's the name?
And this medication
you told me the name for it before we got on. What was the
so
name of
it's
it?
the neurobiological dysfunction where the GLP-1, we don't know what the neurobiology is, but GLP-1 is in the brain. And when you give GLP-1, it changes the reward system, the dopamine. We don't understand it. But all of a sudden, a patient who knew what they were supposed to do could not do it. Yeah. You give him a GLP-1, now they can do it. Yeah. It is chemistry. It's not willpower.
I can tell you from the patient.
But hold on. Let me finish this point. So now when you do this, now that I got the patient's attention, they no longer have that food noise. Yeah. We work on the patient to be like, okay, it's not just the medication. Let's get you to change your lifestyle. Yeah. Let's get you to eat better. Let's go over the basis of nutrition. Most people, when you feel better, you can be better. Most of those patients feel better. All of a sudden, they want to exercise. Yeah. They find time to exercise. Before they told me, I have no time to exercise. You lose the first 10 pounds. You lose that addiction to food. Yeah. You feel empowered that food no longer controls you. Right. You become a different person. And one point that I'm going to make, I'm sorry, I'm cutting you guys because I'm excited about this. We don't have a lot of time left. The studies that showed the SELECT trial, where there was 20% cardiovascular mortality, those people didn't change their diet. So yes, in our clinic, we always do that. Yeah. We do behavior modification, nutrition education, exercise, take enough protein. You need to do this. Right. But even if you don't, the SELECT trial showed us. Yeah. At my primary care practice, most of my patients don't change their eating habits, which is, I don't like to say that, but it's the reality. Yeah. Most of those patients will need to be on those GLP-1s long term. But what's the alternative? The alternative is, what do we tell people? Just eat better and exercise. Come on, you're a closet eater. You can do better. Some people cannot find the neurobiology to do this. So I love to say that.
Not only that, but the difficulty of finding whole foods.
Oh, that's another subject. That's another subject.
Convenience, because if I go every week to the farmer's market and I go to visit the farmer, cool. But if you're a single mom with 2 kids, you're just not going to do that.
But you take an average patient. That's not our patient, right? Because our patient, we tell them what to eat, take enough protein, lift weights. But the average patient who still gets that from a primary care doctor with no nutrition counseling, you look at the SELECT trial, they'll still have 20% cardiovascular mortality. You look at the FLOW study. The FLOW study was on kidney disease. You have decreased progression of kidney disease. So yes, optimally, you want a patient to do all this. Yeah. But again, I'm not going to be the one that's going to say you only get the GLP-1 if you do this. Because what I've done with a lot of my patients, the GLP-1 was able to get the patients to change their minds,
100%.
Change their lifestyle, and now they become and do this.
Right.
So you can rescue a patient from the depths of addiction to food and desperation. It's such a horrible feeling when a patient tells you,
and
food controls my life.
And it's funny because they don't like the image that they see in the mirror, and they don't know how to change it.
So it's so empowered. It's such an empowered.
So for anybody listening, it's not like, yes, in an ideal world, and to kind of like circle back to what Miguel was saying. So like in an ideal world, you want to use the GLP not as a standalone therapy. You want to add the supplements, the amino acids. Miguel and I did a big podcast on amino acids and the importance of that while you're on GLPs, et cetera, et cetera. So in an ideal world, yes, but you as a doctor, you're not going to turn your back on someone who is desperate at their wit's end, doesn't know what to do, because at least that could be the helping hand that will get him to do the right things. And I can tell you from the patient management side, it's been like magic, because going back to what he was saying about the food noise, I think it shuts the reward mechanism. The biggest aspect for us is the psychology, right? Like people just don't desire food in the same way. I've seen people that they don't desire drinking alcohol, which is huge for their health, right? So it helps you stop in your mind this desire for things that are not helping you so that can propel you forward. You can build momentum. And then when you get to that next step, we say, okay, now you don't need the medication anymore. Let's try to see what you can do on your own.
Try to get you off of it.
Right.
Completely.
So,
and this is the only medication, although there are studies that show that when you stop GLP-1, after 1 year, most people regain about 50% of their weight that they lost. There's two things that I get out of this. Number one, if you regain 50% after 1 year, that means you kept 50% off. So if you lost 40 pounds after 1 year, you maintain 20 off. I'm pretty okay with that. Let's work to get back to 40. Number two, it's if you work with the patient and really help them change their lives, there's a higher likelihood that they'll maintain more. Number three, GLP-1s are the only medication compared to like the phentermine, the HCG diet I used to use, that I see more people are able to keep their weight off, because once that addiction, you see past it, patients see a way out. With the other medication, it was just a Band-Aid. This is an actual cure for a lot of patients with diabetes or metabolic disease or obesity. And I want to do something because we don't have a lot of time. Let me cite the other benefits of GLP-1. Number one, 20% reduction of cardiovascular disease, proven by the SELECT trial. Number two, improvement in kidney disease in diabetics, proven by the FLOW study. Number three, now it's showing decrease in sleep apnea. So patients with sleep apnea, they see that when they take GLP-1, that was on Mount Jao, sleep apnea improves considerably, not only because they lose weight, because it changes something to the neural connection.
Well, it's also with the inflammation, reducing it. So they
reducing inflammation, CNS
less obstruction.
IL-6, HSCRP, all those things decrease. Decrease in Alzheimer's dementia, Parkinson's, neurodegenerative disease. Alzheimer's disease is called type 3 diabetes.
Type 3 diabetes, right.
Now they are seeing decreasing in knee pain. So a lot of surgeons, orthopedic surgeons, are sending me patients now because there's a study that showed that you have less knee pain when you take those medications, not only because you lose weight, which is less pressure on your knee, but it's on decreased intra-articular inflammation. So it's a direct effect. Fatty liver, metabolic associated liver disease, which is an epidemic.
Non-alcoholic fatty liver disease in teenagers.
They changed the name.
It's 1 in 3.
Metabolic associated liver disease.
That in teenagers is at
it's an epidemic.
It's 1 in 3 of adults, and it's 1 in 6 of every boy now.
And we never had treatment for that before. So when a doctor diagnosed fatty liver, metabolic associated steatohepatitis, all we used to say, lose weight and exercise. A year later, you see the patient, they gain 10 pounds. Come on, I told you, lose weight and exercise. GLP-1s, both semaglutide and tirzepatide, have been shown to significantly reduce fatty liver. Even if you have some degree of fibrosis already on ultrasound, you can reverse that. So how amazing is this, right? Amazing. Obesity-related cancers, things like colon cancer, breast cancer, and there's about 10 of them. They showed about 15% decrease of incidence of those obesity-related cancers when you take a GLP-1s. And we can go on and on and on and on and all the benefits. And you know, like people are saying, well, that's almost too good to be true. How can one molecule affect all this? It's because it affects insulin resistance and inflammation, which we know as functional medicine specialists, that's the basis of what we're trying to treat. Yeah. And the best treatment so far, the king of peptides, is the GLP.
No, and it's crazy because we've used it. We've used it in people that have lost 100, 150 pounds. They had 100 and 150 pounds to lose. And then we used it on the athlete that wanted to lose that extra little bit of belly fat so he can look super shredded. We've used it there too, super successfully. So, and I know, you know, you have another concept, but maybe we'll leave that for later. Your T-square combo, which is testosterone and tirzepatide, which is another magical potion that Dr. Rudy has.
Atomic bomb.
But listen, if you're someone who is on the fence about GLP, it's really about assessing where you are. Where in the scale of insulin resistance are you? And, you know, our philosophy is not to keep you on this medication long-term. Although if you are someone who has a specific condition, which GLP can treat long-term, we will do that. But the idea is to use this as a tool in your tool belt to get you to where you want to be and propel you towards your goals and beat this epidemic that we are all fighting about, sugar addiction, epidemic of insulin resistance, and obesity. So if you want to join the cause, do you have any questions, issues, concerns?
No, one more point.
Okay.
Although I love GLP-1s, I also hate them. I hate that I have to use them.
Yeah.
but I have to. Because just telling somebody to eat less and exercise doesn't do it. So think about two scenarios, right? From now on. Let's say we do nothing different. We keep doing what we're doing. We don't use GLP-1s. We tell patients, eat better and exercise. Come on, you know what you're supposed to do. Or option number two, we expand the use of GLP-1. In my mind, the way we will deal with the crisis of obesity is we need GLP-1 medication to be subsidized, not for free. Because patients have to have skin in.
Yeah,
they pay a certain amount of money. If they need it, you put them on GLP-1s. Let's say 50%, because 70% of our population is overweight or obese. Yeah. Let's say 50% of those people were on GLP-1 subsidized. In 1 year, 20% decreased mortality rate. There's about 700,000 deaths, cardiovascular deaths a year. 700,000 times 20%, you save 140,000 lives in 1 year. Wow. If you subsidize GLP-1. Cool. There's 30,000 diabetes-related deaths a year. GLP-1 decreases that by almost 50%. So if you do a year, you subsidize those patients, do the math. Awesome. So when I say that this is, to me, the most important breakthrough in medicine since the invention of antibiotics, of penicillin, I mean it. That's a bold statement. Because nothing can affect metabolic disease, because metabolic disease comes from obesity, which is no longer a character flaw. It's no longer a willpower issue. It's chemistry.
Yeah. Okay. Amen to that. Well, listen, this is a very long subject. It's a subject that we're very passionate about. We have a very specific philosophy around it. And yes, when you're with us, you will not lose muscle if you do what we tell you. So if you have any questions, issues, concerns about this medication and you want to get some more information, give us a call and we'll point you in the right direction. Until then, stay healthy.
God bless.
God bless.